Good afternoon, everyone. My name is Tracy Radke with Superior Health Quality Alliance, and I would like to welcome you to the kickoff of our webinar series on organizational initiatives to prevent harm from opioids. Today's webinar is being recorded and will be made available to you in Superior Health Connect. Also, tomorrow morning, you will receive an email with additional information and a link to the recording and either a link to the slide deck or it'll be attached, I'm not sure which. And then, of course, you will receive the quality improvement tool that will be reviewed today. So with that said, we highly recommend you register on Superior Health Connect. It is the quickest way to get these resources and important links, such as the recordings. And there will be other resources on there as well. Throughout the presentation, we will be dropping certain links within the chat. You are welcome throughout today's presentation to enter any questions that you have in the chat. Questions regarding the presentation, you can enter them in the chat, but we'll answer them at the end. Today's agenda includes, you can change the slide. Next slide. Okay, so today's agenda is, is to do introductions so we can meet you and you can meet us. We'll do an overview of the webinar series. Then we'll move into the presentation, educating healthcare staff and providers. Next, we'll review the quality improvement tool, which will be followed up at the end. So now, to get to know you, we would love it if you would enter your name, role, organization, state, and what is your favorite summer activity into the chat. I see names, but not organizations. There we go. Don't forget to put your favorite summer activity. Oh, golf. Okay, don't. I am not a golfer. I tried it a couple times and I am not coordinated for that. So kudos to anyone that can. Going to the lake, yeah, that's a great one. Vacation. Love that answer. We all need, oh, fishing, another good one. Cabin. Yes. Ooh, camping. It's a good one. Haven't done that in quite a long time. Ooh, watching the sunset. I love that. I love seeing all the different colors in the sky as the sun goes down. It's just gorgeous. And canoeing. I haven't done that in a while. That's a great activity. So, oh, more coming in, more fishers, just being outside. Exactly, without 5 layers of clothing or long underwear. Yep, completely agree. Biking, yeah. All right, well, please continue to enter in the chat. Next slide. So here's a high-level view of who is joining the webinar series today. So a total of 52 people registered as of Monday. States represented, we have 5 from Michigan, 38 from Minnesota, and 9 from Wisconsin. They include clinics, hospitals, and nursing homes. Next slide. And here is the Superior Health team, who you will be hearing from throughout this webinar series. Next slide. And who is Superior Health? We are a quality improvement organization whose members are experts in quality and safety. It is comprised of 8 organizations. 3 of them are QIOs. So Metastar in Wisconsin, Improve Health in Michigan, and Stratus Health in Minnesota. We also have 4 hospital associations from Illinois, Michigan, Minnesota, and Wisconsin. And our 8th member is the Midwest Kidney Network. Next slide. So this slide will show you the dates for each webinar and coaching call. We will be dropping the registration link in the chat for you to register for these coaching calls. Highly recommend you attend. It's great. It's a great opportunity to ask questions, learn from others, and just get your projects off to a good start. Next slide. So here are the objectives for this 5-part webinar series: to identify your organization's opportunities to reduce harm caused by opioids. You should be able to describe what are alternatives to opioids for treating pain. You will learn best practices in opioid prescribing and stewardship. You will be able to describe stigmatizing language and its impact on those who need treatment for opioid use disorder. And lastly, identify practices necessary to ensure safe transitions in care for those taking medications for opioid use disorder. Expectations. Over the next 5 months, we encourage you to identify an improvement project, to utilize the quality improvement tools that will be covered at each webinar, to join the learning webinars. I know it's difficult with schedules sometimes, but make every effort to be here if you can. Participate on the coaching calls. Make a pledge. Superior Health has a Shine a Light on Stigma campaign, and you can go in there. We'll give you the link and you can make a personal pledge. Lastly, engage with your peers on Superior Health Connect and with us. So now I would like to turn it over to 2 of my colleagues, Rachel Dibble and Jenny Pritchett. They will be presenting on educating healthcare staff and providers. Rachel, the floor is yours.
Thank you so much. And my name is Rachel Dibble. I am a nurse practitioner by trade. I do have a doctorate in nursing as well, focusing on process improvement, identifying gaps to improve care. So today is, to me, very exciting talk. And the overview, again, this is a summary. So our objectives today are define harm reduction, describe how opioids affect the body, describe the importance of staff education in reducing stigma related to opioid addiction. We do have a polling question, and it is, are you familiar with harm reduction interventions for those who use opioids? And you can just click one of the 3 answers.
Okay, it looks like the polling has stopped, so I'm going to end the poll and share the results.
Great. So we have 17% not familiar, 61% somewhat familiar, and 22% very familiar. So that's great. Thank you for that. Next slide, please. So opioid stewardship, starting just baseline. And again, this talk is an overview that Jenny and I are partnering with. So the idea here is opioid stewardship. And I actually took the definition so we can think about it. So it is defined as promoting the appropriate use of prescribed and ordered opioids while reducing the risk of opioid use disorder, misuse, overdose, and other events. So when we think about that, what that is really saying is, as providers, and if you do prescribe, that we do have that responsibility of monitoring dependence, addiction, misuse, etc. And going forward, we will give you some tools to understand the whole trajectory of when an opioid is prescribed.
Alrighty, so harm reduction with the 6 pillars. I think we had a little history too with the slide before. And if you want, Rachel, you can go over the background and then I will go over the QI pieces at the end.
Okay, very good. So, insofar as background and harm reduction, what we know is that harm reduction strategies are shown to substantially reduce HIV, hepatitis C infections among people who inject drugs. So, as we know, mixing potentially illegal or street drugs with pharmaceuticals is not optimal. So, we need to find these things out before. Reduce overdose risks. Again, meeting the patient where they are in their journey and understanding. So at this point, we want to reduce the risk of overdose. Enhance health and safety. And really, all of that is assessing the patient before prescriptions, during prescriptions, and post. And then anyone else working within, say, a nursing home or any setting also has the responsibility for potentially pointing out that there is an issue, maybe with an overdose, maybe some other medication errors, perhaps. So the eyes and ears watching people on narcotics or scheduled meds in general is highly important. So in December 2021, the Substance Abuse and Mental Health Services Administration, SAMHSA, conveyed, and this is why this is so important. It is the first ever, because the numbers are so high for overdose. The Federal Harm Reduction Summit. It's in partnership, of course, with the CDC and the ONDCP. And so what this means is they're seeing a massive issue with their data insofar as what's happening out in the world. So this was a heavy lift for them to do this in 2021. So they're recognizing the issues significantly to have this sort of support behind us, which is the gift. Next slide, please. So harm reduction, how do we do this? So SAMHSA really is the resource that I highly recommend, giving you lots of just insight, background, really digging deep on harm reduction with opioids. So it is led by the PWUP with lived experience of drug use. So these are people who actually tell their stories. And this is within their program. And those stories are quite powerful when you really understand where that person is coming from and what's happened to them during treatment. Okay. So we want to embrace the inherent value of people. We can't expect that people believe what we believe or that we have the same ideas. But what we can do is listen and meet them where they are and support them where they are. Patient-centered care commits deeply to community engagement and community building. What they have learned and why they did this in 2021 was because the aim was that going straight to providers, yes, that's part of it. We need community support because now it has gotten so large. We need all boots on the ground. And so they're really starting up some initiatives within the community. I think of Nancy Reagan, and that's kind of the breadth of this project that they're doing. So promotes equity, rights, and reparative social justice. And what that really means is no stigma, no bias. That is so hard to do because you have to put your beliefs aside and meet the patient to where they are. One strategy I think that works very well with this is if you can really get to the crux of how potentially a disorder began with them, you often are surprised why this happened, and then you can start building the treatment plan, right? um, Accessible and non-accessible support. This is a very big piece. So we have the equity, the rights, the social justice, and the accessibility and support. Again, that equals community because of the issue. There's so many facets that we have to address. And then meanwhile, we want to focus on any positive change as defined by the person. It could be very simple as I walked by one of my old stomping grounds and I went right on by, I saw the same people potentially, or another experience. These are really important for us to hear where they are. Next slide, please. So SAMHSA also has 12 core principles of harm reduction. Respect autonomy, and this again goes into bias. And when you do a self inventory on yourself, say for 10 patients, and then you write down very honestly your initial thoughts, and then you review it, it really helps you to see where your biases are, because it's hard for us to self assess, right? Practice acceptance and hospitality. A smile does wonderful things. Provide support. Again, community, community, community. Provide many pathways to well-being across the continuum of healthcare and social care. So that means when that person goes into the hospital, goes into, say, skilled for rehab, hip replacement, if they're on MOUD or they're on support, psychotherapy, whatever it may be, that has to go through their continuum of care with where they are. Value evidence practice, on the ground experience. Evidence-based practice is terrific, but as we know, it doesn't cover everything from what we hear and see. The relationship, relationship, relationship. All of this is based on trust. I cannot say enough about that. And it's not easy. Sometimes people don't want friends, so it takes a minute, right? Assist, not direct. Telling people what to do or where they are lacking is not meeting them, right? Promote safety, safety, safety. Naloxone, that is a practice I have personally. I prescribe an opioid, I hand them naloxone. That's up to your policy and procedures of where you are. Engage first. How are you? You're amazed with when you ask that question, what people say if they when they want to talk, right? Prioritize listening. That is the other highlight I will put. Listen, listen, listen. You are really an investigator with your listening. And that's how you need to think about it. You're putting the picture together, you're critically thinking as you're listening. Next slide, please. What are some alternatives? We talk about this at length, alternatives. And because the pandemic, or epidemic rather, is, I still think I'm in COVID, is what it is, they are beefing up some of these non-opioid interventions. Joint injections, particularly corticosteroids. Obviously, you can only get 3 a year. So that's coordination of care, making sure they get the treatment they need, potentially non-opioid. Peripheral nerve block works wonderfully well too for some patients. Trigger point injections, epidural steroid injection for those back lumpectomies that were done 30 years ago. They're going to have back pain now. Radio frequency ablation. Again, you got to go to a specialist. It helps tremendously. Spinal cord stimulation, sympathetic nerve block, behavioral therapy, exercise, exercise, exercise. We know this. And then we have the TENS unit. TENS unit, they've gotten a lot better, I'd say, in the last 10 years. Worth a try for sure. Medications, non-opioid therapy, NSAIDs. So NSAIDs are with inflammation. I like inflammation and pain. So I like to alternate with pain, NSAIDs, and acetaminophen, careful with NSAIDs with your geriatric patients for GI bleeds in particular. And if they're on any kind of antiplatelet or any type of anticoag, they cannot have NSAIDs. Then, of course, you got your kind of steroids, your antidepressants now, Cymbalta 1. It is double indicated for depression and pain. So there's a lot of literature and good outcomes with some antidepressants that address pain. Anticonvulsants like Lamictal often helps with pain. And then your topical medications. A lot of these now, like Voltaren, it used to be prescription, now it's over the counter. All the heat packs, et cetera, et cetera. Positioning, I will add. Positioning is big, particularly with older adults, because they sit in the same recliner, typically, when I used to do home visits. So any kind of movement, organize the pantry. That will help if they're at home. Next slide, please. So opioids, again, alternatives. So not all patients are candidates for every available non-opioid therapy. So that's why IDT is of paramount importance here. And they should all know the multiple ways of available non-opioid treatment options, understanding each modality, mechanisms of action and indications and association and complications. So when you have mechanisms of drugs, pharmacology, you add one drug to one drug to one drug, even if there's no interaction, they still affect how they work. So it's something to look at. And treatment and decisions, existing medical and psychiatric comorbidities and patient preferences should be considered. Again, meet the patient where they are. If they have major depression disorder, they just came out of the hospital for it, we need to talk about that before we start with another plan. Next slide, please. Pathophysiology, or the mechanism of action of opioids. Next slide, please. And what I want you all to think about, I'm starting really at the ground up of what is an opioid. And what I want you to take away from this section of this talk is that I want you to think about the brain as, and just organ. Let's just think of brain, organ, as if it was a kidney, as if it was a heart. Use that thought for the next couple slides, okay? So what is an opioid? It is derived from the opium poppy plant. It's a plant. Opioids are substances that act on opioid receptors in our brain, right? So opioids work very indigenous with an opioid system that we have. We already have it in our pathways in our brain. So acting as potential agonists to the mu receptor, a receptor in our brain, we have a complete cascade of intracellular signals that happens millions and millions of times a day. Dopamine releases in our brain. That's when we feel calm and euphoric and happy, right? Blockage of pain signals and sensation of euphoria is what dopamine does. Next slide, please. Opioids and pain. So down and dirty, opioids are agonists, partial agonists, or agonist antagonists. Opioids lower, keyword, perception of pain. So it's a Band-Aid, right? So it decreases pain stimulus. Receptors stimulated reduces the sensation of pain. Synaptic neurotransmitters. It all happens through your neurotransmitters. These are your dopamines, your serotonins. All of this is happening in your brain, in your synapse clefts, if you will, when all these neurotransmitters go back and forth. And so what happens is that they bind onto the opioid receptor, which is why the perception of pain decreases. Next slide, please. So the main opioid receptors that mediate the effects of opioids are, these are the three big ones. The mu receptor, so this is where you mediate the pain response, right? Your euphoria, but you also get respiratory depression with this receptor. You have GI dysmotility and dependence. This is why bowel regimen is of paramount importance with opioids. They get constipated, then we have a bowel perforation and a big problem. We also have a kappa receptor. So that's immediate pain reliever, if you will. It also will diurese you, meiosis, and dysphoria. Then your delta receptor. So this is when opioids are hitting these receptors. This is what the person feels. And again, this is a moderate pain med or receptor rather, and it inhibits dopamine release of cough suppression. So that's what that receptor does. The sigma receptors, that's the hallucinations, dysphoria, and psychosis. We don't want that. We really don't. And if this is all drug induced, naloxone works except for the sigma receptor. And those are not opioid related receptors that opioids like, put it that way. Okay, next slide. So opioid receptors, they're in your brain, they're in your spinal cord, and they're in your gut. This is why the microbes in your gut, the healthy bacteria flora, if you will, is so important. What happens during an overdose, regardless of the receptor? Respiratory depression. You stop breathing and you die. Next slide. In summary, this is the actual definition again. So a substance use disorder, or SUD, is a disease that affects a person's brain, their organ, right? It's not personality. It's not that you're this or that. It is your brain has an issue. And behavior and leads to the inability to control the use of a legal or illegal drug or medicine. Substances such as alcohol, marijuana, and nicotine are also considered drugs because they love these receptors and they'll hang on to them for people who are susceptible to, say, the euphoria feel. That could be because they are depressed because of a disease or they have a mental health issue. Again, that's where all of these assessments, listening, patient-centered care, meeting them where they are. Next slide, please. Stigma. Next slide. So I've mentioned a lot about stigma and doing inventory on yourself and bias, etc. Because what we know and what the literature says, and even I can give you my personal experience, is that I am biased. I am not equitable when I really did a self-inventory. And what that did for me as a person in the community and in practice, it opened up my world. Let me put it that way, because I never really looked at it. So this is what's super interesting about stigma. So I took the DSM-5 definition of SUD and the ICD code. So DSM-5 is for mental health. ICD is for regular good old-fashioned medicine. So DSM-5 says that this is a cluster of psychological behavior and cognitive symptoms associated with the continued use of substances despite substance-related problems, distress, impairment, such as impaired control and risky use. And it goes on and on and on, okay? But what is the medical code? And I think this is important. We need to code the medical code with the HCC specific coding so that we can understand this patient. So the ICD code is substance use, ICD. So it starts with an F1 format. And all that indicates, the F, is that this is mental or behavior or neurodevelopmental disorders. And then the numeral 1 indicates a mental or behavioral disorder due to psychoactive substance use. Psychoactive. Is it really with these receptors? I don't know. So it's interesting, that's why I bring it up, to look at these codes. We're talking about the same thing, but it is coded differently for psychiatric opposed to medical. And neither one of them really point out, is there an issue then, now, post, what is the treatment? What are we doing? Is there depression associated with this? Is there anxiety, smoking cessation? We can go through the list. This is why I want everyone to be very aware of kind of the ambiguity of these two definitions. Next slide, please. So what is the impact? So in 2022, 54.6 million people needed substance use treatment in the past year. 13 million got it. That can be a whole bunch of reasons. I like to think some of it is coding because we're missing it because we don't see it in the chart. Stigma prevents and impacts patients from prevention and, more importantly, treatment because of stigma and bias. And it takes a lot of courage to seek help. Stigma increases with SUD and mental illness. Of course it does, because they're not getting help. They're afraid. Next slide, please. So what are the best prescribing practices? So I would like to just say on our Connect Superior Health, you'll get the information at the end of the talk. We do have some best practices. This is straight from the CDC, and it is within the last year and a half. They have recommended their recommendations, and they group it into 4. How to initiate, determining the dosage, initial opioid prescription and conducting follow-up, assessing risk and addressing potential harms of opioid use. And then the recommendations are more specific. And like I said, on Connect, there's, I believe, 5, 6 talks about these recommendations broken down. Next slide, please. These are the recommended assessment tools. And in our subsequent talks, we're going to talk about more assessment tools. These are the ones that I personally use. I think that they're pretty painless, time sensitive, and thorough. So this is the screener of the opioid for patients with pain. And this assessment has been revised. And it's the S is the SOAP with another P and an R. So it assesses the patient's risk for developing a problem when placed on long-term opioid therapy. Obviously, a very big decision to make that jump, but it does assess for risk. ORT tool, that's the opioid risk tool. And this is during the treatment of assessing risk of potential abuse. You can also run your drug screens every 30 days. Patient medication questionnaire. Patient is currently taking opioids. So this questionnaire is for someone obviously taking them, but it gets into potentially if there is compliance, not compliance. It gets into many areas that need to be assessed every 30 days before a script happens again. Next slide, please. Polling question number 2. Did this presentation increase your understanding of patient harm reduction? And will you apply this to your practice?
All right. I'm ending the poll, and I will share the results with you.
Great.
Can you see them?
Yes. Oh, I'm sorry. Yes. So not at all was 0. That's great. And somewhat likely 33%, and very likely 63%. Great. It's just keep this top of mind is the idea. So in summary, awareness of growing epidemic of the opioid crisis nationally. And this is, I mean, the numbers are really something, and they just keep getting bigger and bigger and bigger. Culture and non-stigmatizing language and change is really where we are. I can say Medicare is really pushing for health equity, access, etc. Active clinical listening and critical thinking with the patient to ensure patient-centered care, and we meet them there today. Motivational interviewing, really asking questions when appropriate. Often silence, pregnant pauses are nice with this kind of talk. And then the holistic approach with focus on the whole person. So as I mentioned, brain. Yes, It is. We need to be looking at the brain. But this affects their lives, their family lives, all of, their appointments, whatever path they're on. So looking at this person from head to toe is really something that helps them trust you and build a relationship. Next slide, please. Questions?
There are no questions in the chat.
Feel free to put them in the chat. Yes, if you.
So attendees, you can unmute your mic and ask your question, or you can type it in the chat.
Looks like we have a question. What are some examples of harm reduction that we could encourage patients to engage in?
The biggest one, honestly, is if they're in a nursing home, obviously ensuring correct med, correct route, correct patient, checking arm, really doing identifiers. We know in nursing homes too, sometimes other people push the med cart, it can get hectic, right? And then for a lot of the other population staying at home, I'm a real big believer, and Medicare will cover it. And that's the bubble packs. You do mail order, real easy through Medicare, and then they send you the bubble packs. I actually used to see them in nursing homes as well to prevent particularly mud errors.
Yes, and another big one is if they take home opioids, as soon as they stop using them or needing them, they should immediately get rid of them so that they're not available for people to take and use without a prescription. So you can bring those back to your pharmacy, your hospital, and I think even the garbage is fine.
I think too, with the older population, I've seen this a lot. Obviously, people doubling up, tripling up because they can't remember they took their med, or they're taking husband's painkiller thinking it's a Tylenol. So there's a lot of those things. As we know, when people get older, their brains shrink and things can get a little more distant insofar as memory. I used to have patients write down every time they took an opioid. They'd take a picture of it and send it to me. Obviously, I would, and that was a good exercise for them, to be honest, for some accountability. Mm-hmm.
Looks like we have another question in the chat, Rachel. Do you ever use a diagnosis of substance use rather than substance use disorder? For example, if someone has short-term opioid or uses substances occasionally.
Yeah. So to make the diagnosis of someone with a substance use disorder, it's a stepwise approach. I can't call all the guidelines at the moment. I could call half of them, but there's also an algorithm for this. But insofar as I will start with short-term opioid use. There really shouldn't be. If there is, it is typically for 3 days post-surgery. And that is a significant push for short-term, getting away from that. However, if someone is on short-term, say they have had they've shattered an arm and have multiple surgeries, hypothetically, I would not code them until we have gone through all the assessments, all of the appointments, etc., to be able to say they have a disorder, because sometimes these things are situational, and then there's a code for situational. So we have to be the thing is, that's in their medical record forever. So for me, I'm particularly careful so they are not stigmatized with their next doctor. So my personal plan is all the assessments, I usually give 3 months and see where we land. They come in every 30 days. They do their drug test. I check the CSMD. They sign their contract. And then I wait before I make that decision.
Had a wonderful comment about really great overview intro. Yes, and then up next is some of the QI tools that you're also going to use. So any other questions before I start that?
Jenny, hang on 1 second, because I have John who also has some explanation about the last question insofar as the coding for substance use rather than substance use disorder, to make it to make it clearer.
Sure.
Thanks, Rachel. Just want to clarify on the question about using a diagnosis of substance use. Substance use disorder is divided into mild, moderate, and severe. And so you may have a substance use disorder that's mild because you only have 2 symptoms. And then if it's moderate, you're going to have, well, I'm sorry, mild is 2 to 3 symptoms. Moderate is 4 to 5 symptoms. And 6 or more is a severe disorder. So we no longer have kind of just substance use, which used to be substance use abuse, and substance dependence. We now just have substance use disorder, mild, moderate, and severe. And I think what Rachel's trying to explain is that, sometimes if you have somebody with a mild substance use disorder, you may want to wait to see what happens with that before you actually put that diagnosis in, because they may address it pretty successfully with you, and then it doesn't have to end up in their chart. I think it gets a little more difficult, though, when we get towards moderate and severe disorder, because then you really want to back yourself up and have some documentation that there's some significant issues that you're trying to address. So I hope that's helpful.
Thank you, John.
Thank you. Very helpful. Okay, any other questions? All right, well, we'll get on to the QI tools. Thank you, Rachel. That was excellent, excellent information. And now we go on to the project improvement pieces of this. And just a quick introduction of myself. I'm Jenny Pritchett, and I work with Superior Health Quality Alliance, and I'm a quality improvement advisor. And I primarily work with our Wisconsin hospitals within the tri-state region. So I'm very happy to be here and go over this briefly with you. So we're going to go over today the charter and the desired performance statement. Next slide. So these are all optional for you, but they'll be very helpful, and you'll be receiving these tools with the email that's going to have the slideshow presentation. And what a charter, if you haven't worked with quality improvement in the past, the charter is a guideline. So it's basically a guideline and your roadmap to make sure that everyone's on the same page with your quality improvement team that's working on this. So with your charter, you want to make sure that you have your project stakeholders identified, and you want to make sure that you have subject matter experts in all areas of the improvement work that you're doing. You want to make sure that you have a project scope. So you don't, when you're working with your project team, that you're not veering in every which way direction, and that you have the same vision when you're working on your project with your opioid, preventing patient harm with opioids. And it can be a big project. It can be a very small test of change as well. You also want to have, like I stated, that you want to make sure that you all have the same vision and the same goals amongst the team. And also, it's very important to look at to see if you have any barriers or any risk factors that you have identified and can project right at the beginning of the gate, because then you can try, to limit these obstacles or know what to expect, and making sure your project outcomes are realistic to what your current state is as well. And then these all also have examples. And then the communication strategy is very important as well, because you want to make sure you have the same vision and that you're communicating that amongst your team members and your key stakeholders. You obviously list your project team members, all of their names, their roles, and it's very important to put down and have the roles and responsibilities very clear at the beginning of your project to make sure that everyone knows what their role and their responsibilities are so that you can move the needle in the project improvement. We will be sending this template to you following this presentation. Next slide, please. And additionally, you want to have your desired performance statement. So in the desired performance statement, there's a worksheet that we'll be sending to you along with examples so that you have all the tools that you need to make sure that you're successful with your performance improvement. So you want to make sure your goal is listed here. You want to make sure the rationale. You want to have SMART goals so that they're specific, measurable, achievable, realistic, and time-bound. The biggest one is the realistic too. And like I said, you can start very, very small. And then once that improves, then you can build upon it. Sometimes you can have one goal, and those, if you achieve that, then many other areas will be resolved as well. You want to make sure that you have your target, who is going to perform within this. If there's anything that you can identify that they need to do differently to achieve the desired change. When, where, and how as well is very, very important to have that very specific and make sure that everyone has a clear understanding of the end goal. And we will be sending this out to you as well. Tracy or Rachel, do you have anything else to add on these as our QAs? No?
I encourage using it and
Yes.
to be detailed because you will make a difference with this process.
Absolutely. It's like I said, it's your roadmap. It's so that everyone is on the same page so that you're not going in different directions and that you can achieve your goal. All right, next slide.
Yes, and one thing I want to point out, it may seem simplistic, but it really forces you to get granular to make sure everybody understands the who, what, where, when, and how.
Yes, absolutely, Tracy. Thank you. Thank you. So up next is the coaching call that is scheduled for July 23rd at 1 p.m. Central Time and 2 p.m. Eastern. So the purpose of the coaching calls is to assist in the project development and the next steps. We are going to be here to help you with that. And to providing the technical assistance that you need to help you complete your charter, the desired performance statement, or any other QI questions and guidance that you need. We're here to help you. Also, we want you to please feel free to invite other members of your team on these coaching calls, because sometimes if you have your QI team and everyone's hearing the same things at the same time, that's very helpful. And everyone then on your team will have an opportunity to ask the question. So if you have a teams, try to schedule your teams at this time, and then we can work together on your QI work. Next slide. And next is the organizational initiatives. So as I stated, the next is the coaching call. We will be sending this out to you as well so that you can make sure to plan ahead for all the coaching calls and the next webinars as well. Next slide. We will also be sending a brief evaluation as well of webinar 1 and all of our subsequent webinars as well. So your feedback is very appreciated. We value that. Next. So without further ado, I want to put a little plug in for our next webinar. So webinar 2, which will be held August 13th with Dr. Bobby Redwood. It is going to be about introduction to the alternatives to opioids, otherwise known as ALTO. So we look forward to having Dr. Redwood join us for our next webinar in August. He is very, very, he's an ER physician. He's a quality improvement advisor for the Wisconsin Hospital Association and very, very involved in this work. And not only in the education realm, but also day-to-day as an ER physician. So he's an excellent, excellent subject matter expert, and you'll have the opportunity to ask him questions as well. Next slide. And as we mentioned in the beginning of our presentation, we have Superior Health Connect. So if you're not already signed up, please sign up, because it's a shared learning environment to connect with others, which is in the quality improvement space, as well as all of the resources we will put there as well. We will make sure we post all that you need there as well. And the link, I believe, is in the chat, and we will send that out by email as well. And then please take the pledge if you have not done so. Take the personal pledge to shine a light on stigma. So we have the links in our chat. It's very simple. Click on the link to take the pledge. It'll learn about the stigma, and how to use non-stigmatizing language within your practice. And also for your organizations, the promotional media toolkit is here as well, so that you can help others join in the effort within your organization and your community, because we're not going to combat this opioid epidemic until we can stamp out the stigma that goes along with it. Next slide. So lastly, our contact information, and we will send this out as well. For hospitals, it'll be myself, Jenny Pritchett, and Tracy Radke. Nursing homes, the contact information is Candy Hansen and Yvonne Burston. And then other settings, clinics and other settings within the community will be Rachel Dibble. Okay. Also, within the slideshow, we have our resources, and you will be getting those as well in follow up to our presentation. So any last questions that you have for any of us before we conclude? In the chat, we also have the link to the coaching calls if you want to get registered for that right away. Okay, well, I don't think there's any questions in the chat. I want to make sure we don't miss them.
And I want to thank
questions in the
Rachel
chat.
and Jenny for your valuable information that was shared today.
Yes, thank you everyone for joining us, and be sure to join us for the coaching call and webinar too. Thank you.